We can start, Dr. Mitra. You're not audible. Dr. Mitra, you're not
Shubham,
audible.
we are live now. You can start.
A very good evening, everyone. I, Shubham Bharti, and Misbah Kadri will be the moderators for today's session. We welcome you all to Cynodent, Indian Society of Dentistry Webinar Series 2023. Theme for it is Unlocking Trends in Dentistry. I would like to invite Dr. Arifa Farooqi ma'am. She is consultant periodontist and oral implantologist, and the topic for today's session is significance of peri-implant keratinized mucosa. I would like ma'am to please start with the presentation.
Good evening, everyone. Thank you, Shubham, for the short introduction. So I just start with my topic. The topic for today is significance of peri-implant keratinized mucosa. So today what all we are going to cover, that first we will cover the basic of peri-implant mucosa, the basic anatomy of it, okay, and the what is keratinization, why a keratinized peri-implant mucosa is necessary, and what is the controversy about it, okay, and what are the various techniques through which we can augment peri-implant keratinized mucosa, and lastly I will share few of the clinical cases with you guys, okay. So what is a peri-implant mucosa? It refers to the soft tissue that surrounds the dental implants, okay? And it is established during the early stages of wound healing as a result of implant surgery or when we do the abutment connection. So as a result of these surgeries or the prosthetic abutment placement, these peri-implant mucosa is formed, okay? Although periodontal tissues and peri-implant tissues, they both look similar morphologically, but they differ both at histological and microscopic levels, okay. So what happened that the peri-implant mucosa sometimes is covered by a keratinized overlying epithelium, which extends apically up to the mucosal junction and then continue as the alveolar mucosa. If we compare it with the normal tooth structure, there is our attached gingiva, then the mucogingival junction, followed by the alveolar mucosa. When this keratinized tissue, when this keratinized, the most coronal portion of this keratinized gingiva is continued with the cellular epithelium, which is usually non-keratinized, and it faces the abutment portion of the implant, and the most apical portion of this keratinized tissue is ending into a barrier epithelium, which we call as junctional epithelium in a natural tooth, okay. This barrier epithelium joins with the abutment and implant interface, okay. And this barrier epithelium separates the epithelial component of the peri-implant mucosa and the connective tissue attachment of the peri-implant mucosa. Now coming to the connective tissue component, in this, there is abundance of collagen fibers. As I said in the earlier slide, that this peri-implant mucosa is formed as a result of the wound healing. Okay, we did an implant surgery and that wound healing took place. So as a result of that healing, this peri-implant mucosa is formed. So there is abundance of collagen fibers are present as compared to the natural tooth. First point. Second point, that these collagen fibers run parallel to the long axis of the implant surface, whereas in the natural tooth, these collagen fibers, which we called as Sharpie's fibers, they run perpendicular to the long axis of the tooth surface. Okay. After understanding this basic peri-implant mucosal anatomy, we come to know that these peri-implant tissues has a very poor bacterial resistance. Why does it happen? Because there is a compromised vascularity, okay? Again, because it is a scar tissue. And there are no inserting Sharpie's fibers. As we know that there is direct osseointegration, the term which we use for the ankylosis between the implant surface and the bone. There is no inserting Sharpie's fibers, there is direct ankylosis. And again, the collagen fibers, they run parallel to the long axis of the, parallel to the long axis of the implant surface, rather than the perpendicular. And the junctional epithelium or the barrier epithelium in the implant, it is more permeable to everything, more permeable to microorganisms, more permeable to your saliva and toxins. Everything has a direct access to the underlying bone. So all these factors make the peri-implant tissues very poor bacterial resistance. Okay. Now coming to the keratinized tissue. What is a keratinized tissue? Okay, keratinization is a process which confers the stability of the overlying epithelium to the confer the stress. Okay, so the maximum stress comes either on the hard palate. When we chew our food, the maximum stress comes on the hard palate areas and on the attached gingiva. So these two areas have the maximum keratinization in our oral cavity. Okay. It was in the year 1972 when the Lang and Low suggested that a minimum of 2 mm of keratinized gingiva should be present around the natural teeth, so that patient will be able to maintain oral hygiene in a much better way, and there will be a limitation of the pumping effect. This pumping effect causes a limited infiltration of the bacteria. Okay, when there is excessive movement of the gingival margin, it causes a kind of a pumping effect which causes the infiltration of the bacteria. Okay, so they suggested that there should be a minimum band of 2 mm of keratinized gingiva or the attached gingiva around natural teeth. However, other authors came that no, it depends on individual to individual. Some patients who can maintain their oral hygiene in a much better way, they don't need attached gingiva at all. So there was a controversy whether one should go for the augmentation of keratinized tissue or one should not go for keratinized tissue. So a similar kind of controversy was also seen in the peri-implant tissues as well. Okay, so there were a few authors which were in favor of augmenting this, and there were authors that say that no, if the patient is able to maintain oral hygiene, there is no chance of getting any kind of a peri-implantitis, and we do not have to do any augmentation surgeries. Okay. However, in the consensus report of the World Workshop on the Classification of Peri-implant Disease and Condition in the year 2017, they said that there are equivocal evidence and a person has to judge clinically. We have to see the signs of inflammation. If there is inflammation and we see that there is an absolute absence of a keratinized mucosa, so we should be over cautious in cases of implants. As we see in the earlier slides, that peri-implant mucosa is very less resistant to the bacterial attack. Okay, so we have to be extra cautious. So there are equivocal evidence, and one has to go for the augmentation whenever they see that there is a need for it. Okay. Another consensus report of the year 2022, in that also they have said that in the patients where there is a presence of a minimum width of keratinized mucosa with patients with implant supported restoration and when associated with the pathological changes, okay, we have to see the inflammatory changes in the peri-implant mucosa, then the dimensions may be surgically increased using autogenous graft or soft tissue substitutes with evidence of proven efficacy. It is the latest 2022 consensus reports. Okay. So why the keratinized mucosa around implant is important? First one, that it provides a better soft and hard tissue stability. The patient will be able to maintain his oral hygiene in a much better way. There would be less plaque accumulation, better hygiene maintenance, and then definitely when there is a better hygiene, there will be lower incidence of peri-implant mucositis. Another study by Roccuzzo, he said that the prevalence of peri-implantitis in patients which have a less than 2 mm of keratinized mucosa, it ranges from 23.8% to 74%, which is quite high. Okay. So what are the various techniques to augment the keratinized mucosa? First one is the free autogenous graft, which includes free gingival graft or free connective tissue grafts, in which the free gingival grafts are considered as the gold standard. It was first described by Bijon in the year 1963. The term FGG refers to the harvesting of keratinized epithelial connective tissue from its original site and its placement at a different oral site. Okay. So FGG is considered as the gold standard and gives the most predictable results in augmenting keratinized tissues. The variants of free gingival graft include strip technique, in which instead of obtaining a full big free gingival graft, we just harvest a single strip of free gingival graft. Okay, so by this we will reduce the size of the donor site. Okay, we will reduce the size of the wound, and because of the narrow wound margin, there will be rapid epithelialization and rapid healing of the wound site. It is a variant of free gingival graft. Another variant is the accordion technique, in which on this free gingival graft, they give alternate incisions and then spread it. So a small size of free gingival graft can be spread and can be used for a larger site. Okay. The other techniques to augment free gingival graft include apically positioned flap. It is the most basic technique to augment to augment keratinized mucosa, but there are high chances of rebounding. Okay, because we stabilize this flap at the base, but there are very high chances that it will come back to its original position. So it is very unpredictable technique. Okay, another technique is pedicle grafts. What are the limitations of these autogenous techniques? One, that there is a donor site morbidity. Definitely, when we are doing a second surgical site, so the morbidity is going to increase. There will be two surgical sites. One is the donor site and one is the recipient site. Second thing is the poor aesthetics. When we do a free gingival graft, it gives a very patch-like appearance. I will show you the clinical cases in the upcoming slide, then you will be able to appreciate it. And also the limited supply of the graft. If we have to augment a very large area, then we can't harvest that much from the palate, right? So these are the few limitations that we have to address. Because of these limitations, researchers came up to certain alternative materials such as acellular dermal matrix allograft, tissue engineered bilayer cell therapy, and xenogenic collagen matrix. Okay, so these are the few techniques and materials which are being used nowadays for the augmentation of peri-implant keratinized mucosa. Now, I just want to show you few clinical cases just to get a rough idea of what does it means. Okay, so the first case here, we have already placed the implants inside. Okay, and you can appreciate that there is a very minimal amount of keratinized mucosa. Here it is still around 1 mm, but at this point, if you appreciate, it is lesser than 1 mm. Okay, and it is a large area. Okay, so we planned that we will go for the augmentation of keratinized mucosa for the longevity of implants. What we did, we just replaced an incision parallel to this mucogingival junction. Usually the mucogingival junction is at this point, okay? But because of the large augmentation procedures, this junction has shifted over here now. Okay, so we have to push this mucogingival junction back to its original position over here, somewhere here, okay? So what we did, we elevated a partial thickness flap and sutured it apically by using a T-mattress suture technique. Okay. Then we harvested a free gingival graft. Free gingival graft was harvested from the palate by taking care of the anatomy. Then this free gingival graft was sutured and immobilized onto the recipient bed by using various sling sutures and interrupted sutures. Okay. Now you can appreciate this is a 1 month post-operative view. Okay. Now this mucogingival junction has come here. A thick firm tissue has been formed. Okay. And as I said, that it has a poor aesthetic. The limitation of free gingival graft is that it gives a poor aesthetic or a patch-like appearance. And you can see that this is a patch-like appearance. Okay. However, this has a bit improved after a period of 6 months. Now this keratinization increase, if you can appreciate this darkness, okay? So there is increase in the keratinization. Okay, so this was the pre-operative view after the implant placement. Now we have completed the prosthesis and a thick band of connective tissue has formed. Now the patient will definitely going to have a good oral hygiene. Coming to the second case, in that also, if you can appreciate here, there is absolutely no vestibular depth is totally obliterated. There is no attached gingiva or keratinized mucosa. However, at this place we have abundant of a keratinized mucosa, but at this place, if you can appreciate, there is no keratinized mucosa. Implants were already placed inside, so we planned for the augmentation. But now we used a different technique. The basic preparation of a recipient bed will remain same. We just elevated a partial thickness flap and sutured it apically. Okay, with the help of a 15C blade, we give the partial thickness. Flap was elevated and it was sutured apically with the use of T-mattress sutures. Then the dimensions of this was measured. Since it was a very big area, if you can appreciate, it starts from this central incisor and going to this first premolar. It was a quite large areas. Okay, so instead of harvesting that big free gingival graft, we went for the variant of the free gingival graft, which I mentioned earlier, that is strip technique. In that, only a thin strip of free gingival graft was harvested. Two strips actually. One strip was harvested from the adjacent side, and the one strip was harvested from the palatal side. Okay, so these two strips was stabilized apically. I can show you here. These two strips were stabilized apically over here, and this remaining recipient bed was covered with the alternative material, that is your xenogenic collagen matrix. Okay, the remaining recipient bed was measured, and according to that dimension, this mucograft was cut and it was sutured over here. Okay, so the rationale of using this apical strip, this is known as a combination approach, in which we are using both autogenous graft as well as the alternative material as well, is that we are using a strip of free gingival graft because it will act as a source for the cells. Half of the keratinized tissue will come from these strips, and half of the keratinized tissue will come from here, will come from the palatal side, and a good keratinized tissue is going to form. Okay, now you can appreciate. Okay, here, if you remember, I showed you in the initial slide, there was absolutely no keratinized tissue over this place. Here it was there. Now it was around 9 mm of keratinized mucosa we were able to form. We started from 0. Okay, so this was a pre-operative here, and now you see how much we have achieved over here, here, and here. Okay. Now another case, similar case, very straightforward. If you can see that there is no keratinized tissue over here, there is directly alveolar mucosa. Okay, we have done the second stage surgery. Then we thought that we should go for the augmentation procedure. Then we harvested a free gingival graft, as I shown in the first in the first clinical case, and this FGG was stabilized over here, and this was post-operative view. This was 3 months post-operative for this case. You can appreciate, and as I said that there is a keloid or patch-like appearance, so you can appreciate this poor aesthetic thing, which poor aesthetic was not visible in this case, where we use the xenogenic collagen matrix. Okay, here it is well merged with the adjacent tissues. Another case here, if you can appreciate that there is absolutely, I think around 1 mm of keratinized tissue over here, and this patient complained that he has brushing discomfort. We had already placed the prosthesis, but he came back to us and said that he is having a difficulty in maintaining his oral hygiene, and he feels pain whenever he tries to brush these implants supported prosthesis. So we planned for a for augmentation procedure with the use of xenogenic collagen matrix. In that also, if you can see, a good amount of keratinized tissue was achieved. Okay. So these were my few clinical cases. So coming to the conclusion, we can say that a band of minimum amount of 2 mm of keratinized mucosa, more than or equal to 2 mm around implants, is associated with the lesser brushing discomfort, lesser plaque accumulation, lesser inflammation. Okay, when the patient is able to maintain his oral hygiene in a much better way, there won't be any plaque accumulation. Okay, when there is no plaque accumulation, there won't be any inflammation. No inflammation, no mucositis. No mucositis, no peri-implantitis, and then there are lesser chances of the implant failure. Okay. If we come to the implications for the clinical practice, we can say that less than 2 mm of keratinized mucosa, whenever we see in our practice that there is a lesser than 2 mm of keratinized mucosa is present, so we should go for a surgical intervention to augment the width of keratinized tissue whenever there is a possibility or we see the signs of inflammation. So there is the question that what type of grafting material one should go for. One should always try to go for the autogenous graft, that is your free gingival graft. That is still the gold standard. The various xenogenic collagen matrices has come into the market, but still the results are not that good as compared to the free gingival graft. If there are some limitations such as donor site limitations, patient is not ready for a second donor site, then you can think of these alternative materials. Okay, or these alternative materials are good when there is not complete absence of keratinized tissue. There is some amount of keratinized tissue is there, and then you put a xenogenic collagen matrix or the soft tissue substitute, so that would be a good choice. Otherwise, one should always think of going for an autogenous grafting. Okay, autogenous grafting should be favored in sites with complete absence of keratinized tissue, and soft tissue substitutes could be considered in patients with limitations in the donor area or when a limited amount of keratinized tissue is needed. Okay. So these are the few articles which I will if someone is interested in knowing more about these things, so these are some good articles about knowing all the theoretical part of it. So one can go all through these references. Thank you so much.
Thank you so much, ma'am, for such an informative session. As you beautifully and very simply explained all the things in this session. Ma'am, we have a few questions for you from participants. Should I begin, ma'am?
Yes, please.
Ma'am, as you explained the importance of keratinized gingiva around dental implants, can you please explain in brief about the clinical significance of keratinized gingiva around dental implants?
Yes, as I told earlier that there is the differences in the histological level. Okay, although they appear morphologically similar. Okay, but there are differences at the histological site. So we have to think in that way. Okay, so we have to be over cautious when we are treating a dental implant. If we see that the progression of gingivitis to periodontitis is not very rapid, but the progression of mucositis to peri-implantitis is very rapid because of the anatomical variations. Okay, so whenever you see there is a lack of keratinized mucosa, you should go for the augmentation procedure. Okay, because it will definitely going to increase the longevity of dental implants.
Okay, thank you so much, ma'am, for explaining so nicely. I would like to thank the founder and CEO of Cynodent Dr. Anmol Bagaria, ma'am, and co-director of Cynodent Dr. Ashish Chandra sir, and also my co-moderator Dr. Shubham Bharti, and also thanks to all the participants who joined us by today. I kindly request all the participants to please like, share, and subscribe our YouTube channel for more updates and webinar. Thank you so much, ma'am, for such a wonderful session, and thank you everyone for joining us today.
Thank you, Cynodent, for the